Opportunity to share my deliberations. So I will be speaking on US infraclavicular. Is a single injection below axillary artery is all that is required? Greetings from my hospital. We are a 300-bedded hospital which runs a fellowship or a fellowship center, and these are my disclosures. So a 72-year-old patient with a fracture both bone forearm, known case of COPD, CAD, diabetic and hypertension, was posted for open reduction and internal fixation. So based on the surgical factors and dermatomes, myotomes and osteotomes, these are the approach options which have. But based on the patient factor, my choice is lateral infraclavicular block. And this is the way I did my lateral infraclavicular block. This is the pec major, the pec minor. You can see the axillary artery. You can see the axillary vein, the lateral cord, medial cord, and posterior cord. In this patient, I got it, but maximum time you see only the lateral cord. And I do an in-plane needling from cephalad to caudard. I will just appreciate a facial click and put my needle tip just at the 6 o'clock position. And as I start injecting, you can see a good U-shaped spread of drug and displacement of the axillary artery anteriorly. And I deposit around 25 to 30 ml of local anesthetic. How many of you agree with this technique? Vote. Fingers up. So I have many to prove it. Fingers down, many. So let's review the literature, what the literature says. So coming to the cadaveric study, all the three authors are here in the conference. You can clear your doubts. So they did an ultrasound-guided single needle tip placement below axillary artery in a cadaveric study, and what they found. There were two cadavers. In both they injected below the axillary artery. One was frozen, and one they immediately dissected. And what they found, in cadaver 1, there was spread of latex dye to the lateral cord and the posterior cord. In cadaver 2, which was frozen, the blue latex engulfed all the three cords. The authors concluded that a single injection of 20 ml below the axillary artery is what is required, but you have to confirm it by your clinical studies. There was another clinical cadaveric study, why your infraclavicular block fails. So they performed bilateral infraclavicular in 20 cadavers. Lidocaine 0.5% with methylene blue was injected. The primary endpoint was the failure of the ultrasound infraclavicular. In 33, they were successful. In 7, the blocks were unsuccessful. The authors concluded it was not the placement of the needle tip, it was the spread of drug to a thoracocapsular space between the subscapularis muscle and the serratus anterior muscle. Can the facial layer influence the spread of dye, which Dr. Sandeep Diwan, they have shown that there is no facial septa in their cadaveric study. But in this cadaveric study, they found they have shown that there are well-defined septals in 7 cadavers which they dissected. In 6, the facial layer impeded the spread of drug, but in 5, there was no facial layer. So the facial layer adjacent to the neurovascular bundle are common, but it is not invariably present. The most common location of the facial layer is below the axillary artery. That's why the appreciation of a facial click when you are going just below the artery is one of the sensations which can give you a successful block. And the optimal spread of injectate is by a single injection below the axillary artery using 30 ml of drug, or by a multiple injection which you want. Now coming to the MRI studies. According to the MRI study, they found 3 cords, and it was almost within the 2 centimeter of the axillary artery. And what they concluded, that the injection site that is closer to the cord, that is cranio-posterior and adjacent to the axillary artery, is what is required. Now coming to the clinical trials, the double bubble sign, which we always tell to get it, the inferior bubble is the local anesthetic and the superior bubble is the axillary artery. And if you get a double bubble sign, the success rate is almost 100%. Now, this is a study which was conducted in 2010, which they compared single versus triple injection, and what they concluded that a single point injection posterior to the axillary artery is what is required. There is another study comparing single or triple injection. The conclusion was the success rate and onset of the complete sensory block is not enhanced by a triple injection, and a single injection is what is enough. What is the end point of a successful ultrasound block? The combination of a facial click, which I showed, a U-shaped distribution of local anesthetic, and anterior displacement of the axillary artery when you are injecting the drug is the end point of a successful ultrasound infraclavicular block. Now, this is a study again by Dr. Sandeep Diwan, ultrasound-guided infraclavicular without neuron stimulation in a patient with crush injuries, and there were 14 cases of crush injury of upper limb for amputation below elbow, and the LA was deposited below the axillary artery in a 6 o'clock position. The author's recommendation, needle tip placement below the axillary artery and injection of LA posterior to axillary artery is what is required to get a successful infraclavicular block. Now, this is a study in 2013, the complication of single injection ultrasound-guided infraclavicular block. It was done in 627 ultrasound infraclavicular. There were 4 transient neurological symptoms, 2 possible last, but the success rate, 94% in experienced and in non-experienced hand, 93%. And what was the conclusion? A single injection posterior to the axillary artery is safe technique associated with the high success rate regardless of the expertise of the anesthesiologist performing the block. This is a study comparing single and double injection technique where they gave around 25 ml of local anesthetic. There was no difference between the single injection group and a double injection group. The conclusion was a double injection block doesn't provide any significant advantage compared to the single injection counterpart. This is a recent study which came in May. They compared a single injection with a triple injection, 30 patients in each group, and the sensory onset was slightly less in a single injection group, but the motor onset time, the composite sensory motor onset time, and mean time to perform the block was less in a single injection group, but rest of the parameters were almost same. The conclusion was a single point injection method has a shorter performance time with a similar onset time with less procedural complication compared with the triple injection technique. So I gave that block and I assessed it by by push, pull, pinch. So my block was successful, and that 72-year-old patient had a very good block. He underwent this surgery without any complication. So I was ready for action. So the take is a single injection below the axillary artery. Appreciate the facial click when you are targeting your needle at the 6 o'clock position. As you start injecting, you see a good U spread of drug, and as you are injecting, you will see the anterior displacement of axillary artery. If these 3 triads are successful, a single injection below the axillary artery is what is required in an infraclavicular